Well, good evening, everybody, and I'm glad you came out in this great weather. What happened tonight? Thank you, Representative Scanlon, for arranging this important forum to address the heroin crisis in Connecticut and on the shoreline. According to the Centers for Disease Control and the CDC, heroin use has increased across the United States among men and women across most age groups and all income levels. Heroin use more than doubled among young adults ages 18 through 25 in the past decades. From 2000 to 2014, nearly 500,000 people in the United States have died from drug overdose. Opioids, primarily prescription drug pain relievers, and heroin are the main drug associated with overdose deaths in the United States. According to the CDC, 2014 data demonstrates that the United States opioid overdose epidemics include two distinct interrelated trends. First, in a 15-year increase in overdose deaths involving prescription opium pain relievers. And second, in a recent surge in illicit opioid overdose deaths driven largely by heroin. Connecticut is not immune to this trend and has not seen a dramatic increase in rise of prescription drugs and heroin abuse over the last few years. The CDC also tells us that the strongest risk factors for heroin addiction, in addition to prescription drug opioid painkillers. In fact, the National Survey on Drug Use and Health reports that people who are addicted to prescription opioid painkillers are 40 times more likely to be addicted to heroin. The CDC states that we need to respond to heroin epidemic in three ways. First, prevent people from starting heroin use by reducing prescription opium painkillers abuse. We need to improve opioid painkiller prescription practices and identify high-risk individuals early. Second, reduce heroin addiction by ensuring access to medication-assisted treatment, MAT. This means treating people addicted to heroin or prescription opioid painkillers using a combination of medication, counseling, and behavioral therapies. And third, reverse heroin overdose by expanding the use of Narcan. Now, Narcan is a life-saving drug that can reverse the effects of an opioid overdose when administered in time. In fact, next month, the Guilford will host its first Narcan training, which is open to the community. And if you're interested in this training, you can contact our Guilford Youth and Family Services Department to register for that training. As a member of the Public Health Committee, State Representative Scanlon has become one of the legislators' leading voice when it comes to preventing and combating substance abuse. In 2015, he co-sponsored and helped pass Public Act 15-198, an act concerning substance abuse and opioid overdose protection. This landmark legislation required education for doctors on the dangers of overprescribing, enacting safeguards against doctor shopping, and gives pharmacists the authority to provide life-saving anti-overdose drugs like Narcan over the counter. And as first selectman, please join me in welcoming State Representative Sean Scanlon.
Thank you, Joe, and good evening, everybody. You know, I was driving over here and I was a little worried about what kind of turnout we were going to have. And it's a good thing to see so many people, but also speaks volumes to the concerns that people in our community have about this deadly epidemic. As Joe said, my name is Sean Scanlon. I have the honor of representing Guilford and Brantford in the State House of Representatives. And tonight, we are going to have a very informative, I hope for you, panel discussion that touches all the different facets of addiction in our society, in our state, in our community. And before we get to that panel, and I should say that after the panel goes on, we're going to leave the balance of the evening for your questions. There's a microphone in the front of the room here, and so once the panel is over, I'm going to ask people that do want to ask questions or tell their story or make a comment to come up to the mic. We'll turn the mic on and you can share your story with all of us here. Connecticut, and New England in particular, is in the midst of a full-blown crisis when it comes to opioids and heroin addiction. You see this on the news, you read it in the newspaper. There is no community in this entire state that is not a victim of what's happening right now. And we certainly, as a town, are not. Even though we sometimes like to think that it would never happen here. It would never happen to our kids. It would never happen in our community. But it does. We've lost 5 people, 4 men, 1 woman between the ages of 24 and 33 since 2013 alone in our town from heroin overdoses. So this is real, it's happening here, and for me as a legislator, I didn't really know a lot about this issue when I ran for office in 2014. But in December of 2014, after I had won, I met with a lot of different groups in the community, and one of the groups that I met with was Guilford Day. And I've told the story a lot, and so if you're hearing it again, I apologize for boring you, but I sat down in the elite room, down the hall, with students and parents from Guilford. And as somebody who went to the high school not too long ago, I felt like I had a good grasp of what was going on, and I was blown away by what I heard from these students, talking about how the dramatic rise of prescription drug abuse in our schools. And that then, as the first selectman said, CDC says 40 times more likely to try heroin if you've tried prescription drug abuse. Why? Well, because when you are unable to secure prescription drugs anymore because of their cost, you turn to things that give you a similar high. Heroin is $5 a bag right now in New Haven, not very far from here. So, I met with Guilford Day and they told me about this issue and I was blown away by this and I decided that I was going to try to do something about this. And as a member of the Public Health Committee, as Joe had alluded to, I had the fortune of passing my very first bill as a legislator on this issue. It was a bipartisan bill. It passed the House and Senate unanimously. The governor signed it. And it's doing good work, but there's still so much more work to do. And there will never be a mission accomplished banner that we will be able to raise as policymakers when it comes to winning this battle, because it's just not going to happen. So it's incumbent upon us, therefore, as public officials, to do our best to make sure that it's not getting worse, and to make sure that people who are fighting this battle every single day have access to the treatment that they deserve as citizens and as people, frankly. And so tonight, what I really want to do is share with you, through this panel, some information about why this is happening, and information about what we can do to fight back. And I guess I'll just close by saying this, that as people in this room who are in recovery know, the first step towards recovery is admitting that you have a problem. And it's time for Connecticut to admit that we have a problem. And I am doing my best to raise my voice and use my platform as an elected official to talk at the top of my lungs about the need to get serious about this. and the need to work in our communities every single day with the people on the front lines. These individuals who are sitting up here are on the front lines of trying to save lives. And it sounds sometimes like, you're trying to be too serious, but we're really talking about people's lives here. And if this forum can save just one person, we all tonight will have succeeded in a very small way, but a big way at the same time. So, without further ado, I just want to introduce a great panel that we have tonight, and I'll go from left to right here. Dr. Dan Tobin, he's at Yale Medical School. He's also a member of the Prescription Drug Task Force, and Dan was actually one of the people that I first talked to in January, February of 2015 when I first got elected about writing the bill that we ended up passing. So I'm super honored to have him here tonight. Sue Kruzek is a parent from Guilford who's going to share the story of her son Nick and her family. Commissioner Delphin Rittman, Dr. Commissioner Delphin Rittman. She is the Commissioner of the State Department of Mental Health and Addiction Services. Dana Hillner is the Prevention Coordinator for for Guilford Day, rather, the group that I mentioned, and she'll tell you a little bit about. Officer Mary Lisa Anania, she is a member of the Guilford Police Department. Detective Sergeant Tim Bernier, also from the Guilford Police Department, and rounding out the panel is firefighter paramedic John Planis. Just join me in giving them a round of applause. So Dr. Tobin, I'm going to kick it off to you first, and if you could just all go down the line and just share briefly about what your role is within this particular issue that we're talking about, and then I'll get to some questions from myself, and then we'll open it up to questions from all of you. So, Dr. Tobin, you can just use the...
Thank you. Thank you so much. Can everybody hear me okay? No. Test?
No.
There you go.
There you go. Very good. Thank you, everybody, for being here. My name is Dan Tobin. I'm on the medical faculty at the Yale School of Medicine, and my primary role is as a teacher. I'm a primary care doctor. I take care of a whole spectrum of disease and trying to keep people healthy. But I also work with the Yale Internal Medicine residency program and the director of our outpatient center at the St. Raphael's campus. And one of the things that has for years and years and years become obvious to me is that doctors are part of the problem and part of the solution, and need to be. And that most of us, as we go through our training as medical students and then as residents, don't have good role models to learn how to do this well. There was a study that found that it's a few years ago, of the nation's 133 medical schools, only 5 of them had any sort of mandatory teaching on how to treat pain. And the reality is that in primary care, we really handle most of the pain complaints, and pain specialists are very few and far between. There's only nationally about 4 board-certified pain specialists for every 100,000 people who have chronic pain. And so what that means is the primary care doctor is poorly trained to deal with it, but the person who's dealing with it most often, and patients suffer a lot from chronic pain too. It's not just addiction and misuse, it's people who are disabled by illness and injury as well. So there's that balance, right? How do you balance the safety piece of all this and still helping people live more functional and full lives? And so I try to teach about this. I've taught our students and our residents. I've joined in the past few years, more on a sort of policy point of view. A few years ago, I was invited by Jewel Mullen, our former commissioner for the Department of Public Health, to come on up into Hartford and work with her and a group of other policy folks to try to figure out what can Connecticut do to approach this in a very sane way. I went to Washington and it was wonderful hearing how other states were approaching this problem. And last year, I had the honor of helping to moderate and facilitate some discussion among some of the different branches of our state government. And the work that Representative Scanlon is doing, it totally support and is amazing. And I'm very grateful for all your efforts. It's really my honor to be here with you tonight.
Okay, I'm Sue Kruzek, and almost 2.5 years ago, I lost my son Nick to an overdose. 20 years old. Nick has a story to be told, and I'm hoping that by sharing Nick's story, it's not easy. not getting easier, but my hopes are to help bring awareness and help break the silence of shame and stigma that seem to go hand in hand with addiction. That's all I have to say right now.
Thank you, Sue.
Good evening, everyone. I just wanted to say thank you for the invitation to be here. I also want to say thank you for sharing your story, because I think it does help to raise awareness of this really health crisis that we're experiencing. I'm Commissioner Miriam Delphin-Rittman, Commissioner of the Department of Mental Health and Addiction Services. And this truly is a health challenge that we're experiencing here in Connecticut as well as nationwide. When we've been looking at some of our data, we've found that heroin use and opioid addiction has replaced alcohol as a primary drug of choice for individuals that are seeking services within the DEMA system of care. And so we're seeing significant increases in individuals that are grappling with this as an issue. DEMAS, I don't know if folks know, but DEMAS, we primarily serve individuals. In many ways, we're the safety net service provider in the state. So individuals who are underinsured, individuals on Medicaid, or individuals without insurance. We run a number of state-operated agencies. We'll also fund community services. And our aim really over the years has been to really fund and to provide a range of options, because we know that there's want to be able to offer multiple avenues and multiple pathways into treatment. So often we say, there's no wrong door into treatment. That has been our goal in terms of trying to shape our service system. So we offer detox support services, residentials, a range of different residential services, outpatient, as well as long-term recovery supports. And so that's the treatment piece. There's a lot, though, that we think it's critical to do in terms of prevention. And so we've been partnering with other state agencies around sort of getting some of the messaging out around ways to manage medications. That we advertise prescription, where around the state prescription drop boxes are located, or advertise drug take-back days. Often people may have additional medications after an illness course, and it's important to really turn those in, so extra medications aren't available for individuals who may be struggling. So those are just some of the things. We also have a number of partnerships with other state agencies. An individual before mentioned that medication-assisted treatment is often viewed as really one of the treatment options of choice for individuals that are grappling with opiate addiction. So we offer 25 methadone clinics across the state, and also are partnering with the Department of Corrections to be able to offer individuals who are imprisoned and who enter prison on methadone, to allow them to be able to continue on methadone, so that when they are released, they're already connected to the treatment of choice. And so that's a pilot that's going on right now in the New Haven area with New Haven Correction Center and Department of Corrections. So those are just some. We'll have other opportunities. Real quick, another big thing that I'm really trying to do is to let people know that treatment is available and recovery is possible. And so we've been trying to do a lot around disseminating information around the availability of different types of services and supports that are available. And so I have a poster here that I'd like people to take. It's also on our website, but essentially what it is it's a list of assessment centers all over the state. And there are numbers connected to these as well. And so if an individual goes to one of these centers, they can be assessed and then linked to the appropriate level of care, whether it's detox or inpatient or outpatient, or whatever level of care is appropriate for them. So I'll stop there, to allow time for conversation. But I also want to just thank everyone for coming. I think that conversations like this are so critical. So thank you, everyone, for being here.
And I want to thank Sean for putting this together. Thank you. We worked very closely with Sean Scanlon repeatedly here in the Guilford community. And for those of you that don't know what Guilford Day is, DAY stands for Developmental Assets for Youth. And our focus is on bringing the community together to help create a healthy, positive environment for our kids. and to help our kids make healthy choices. And we really work primarily on prevention. I want to tell you about a program that we do have called Safe Homes that I have a sign-up sheet here if you're interested. But this is our effort to get parents communicating and being part of a database of like-minded parents that want to know that when their kids go to a party, that there will not be alcohol, there will not be drugs at that party, that you open the lines of communication with the other parents so you can ensure that when your kid goes to a party, they're in a safe environment. So I do have sign-up sheets here. That's just one of our programs. We've also worked very closely with Mr. Scanlon on drug take-back days. Those are just a couple of the programs that we've done. One of the things I want to share is I think that a community conversation like this is so important when it comes to this particular crisis because we need to open the lines of communication. I think a big problem is that there's a stigma attached to addiction, and we need to open the communication and raise the awareness so people that do have a challenge with addiction can get the resources that they need, get the help they need, talk to people openly about it, and this is a huge start to that process. So I'm very, very pleased to see everybody here today. Also, I think we need to change the language of addiction. Addiction does not discriminate. Addiction affects everybody. So whether it's Guilford, whether it's any other community, it doesn't matter if a kid is highly academically inclined, an athlete, somebody who's not academically inclined, it does not discriminate. It affects everybody. And so this is something we need to take seriously for all of our students and for everybody in the community. And also changing the language of addiction. Addiction is not about abuse. Addiction is a disorder, and we need to position it as that. So that's just one of the thoughts I'd like to leave you with.
I'm Officer Mary Lisa Antonia. I'm with the Guilford Police Department. I've been there about 3 years. A couple months ago, I was assigned to People Liaison Officer with Guilford Day. I've been working with Dana, going over different things that we can do in our community. I'm just here to talk about what the police department deals with and our services that we can provide that include the prescription drop box that's in our station.
Good evening. Detective Sergeant Tim Burney with the Guilford Police Department. I've been an officer here for 14 years, and as you can imagine, we kind of see the best and worst of people on a daily basis in what we do. Just to briefly touch on what our role is in this conversation and kind of our role in the communities, the obvious, we handle the criminal element. If there's any kind of a investigation into a narcotics operation of any kind, we handle that aspect. But the underlying scene that's not seen as often is when there's not a criminal element, and there's not always a criminal element. I mean, our goal is not to lock people up, it's to help people. I mean, life preservation is our number one mission. But our patrol officers and our patrol sergeants who are the first responders to an overdose or to a drug case, and the majority of the time, they're the ones that are going to get out there and they're going to take life-saving measures until our medics can arrive. And they're the ones that are really kind of getting down and dirty and saving lives, and we try to stabilize the scene until they can get there. But aside from that element, it's getting people in touch with all of these other resources that are on this panel that they may not know how to get in touch with. When deemed, we can go through some kind of court-mandated counseling or mental health issues or anything medical related. But our goal is kind of a liaison to all the other elements out there that we can't personally provide, but we know how to get people in touch with. So it's kind of a multifaceted response. It's much more than just any criminal investigation or the criminal element of it, but getting people in touch and stabilizing any scenes until the medics can get there and do the amazing work that they do. I know I'll have an opportunity to talk more about it, but just to kind of move it along and pass it off.
Hi, my name is John Planis. I'm a Guilford firefighter paramedic. I've been here for about 9 years now, and basically I think it's a great idea to have a forum like this. It's something that's very important. I think it's important that we educate the public. We have to start educating our kids young. We have to let them know about what's going on and the things that they're going to be exposed to once they start growing up. I know I put the fear of God in my daughter. She's visited a police department many times. I've showed her the inside of a cell where you can end up. It does put the fear of God in them. These are things that you have to do as a parent, and this is a great opportunity to get the word out for people to understand, how serious this is. I came from Brantford. I used to be a firefighter paramedic over in Brantford. So I've seen things happen over in Brantford, and I see things happen here in Guilford. And it's something that is a problem that we have to deal with. So when you see me, it could be a good thing, it also could be a bad thing, but I'm here to help. So there's a lot of things that we can utilize as paramedics here in the town, especially where we spoke about the medication Narcan, and we'll talk a little bit about more later on as the forum continues. But it's something that we utilize for any type of overdose that can save your life.
Thank you. Thank you. I just want to share some numbers with you. I know First Selectman shared a few Just let this sink in for the rest of this conversation. Today in Connecticut, more people die from these overdoses than they do from car accidents. The trend you used to see on the highway, you'd see seatbelt ads, things like that. We need to draw attention to that in the same way that we did to this. And I'll tell you why. In 2015, we had 723 people in the state of Connecticut die from a drug overdose. Many different drugs. Of that 723, 415 of them were due to heroin. And another 107 on top of that were from fentanyl. Fentanyl, if you're not familiar with it, is something that drug dealers now lace with heroin. It's 10 times stronger than morphine. And so, you know, the folks in law enforcement can maybe talk more about this, but when a drug dealer gets a weaker product and they sell that on the streets, sometimes their clients come back to them upset that they didn't get as high as they once did. So now these dealers are cutting that heroin with fentanyl, which is extremely, extremely lethal. So almost 500 of the 723 were from this specific thing. But what's worse is when you compare it to the numbers in the past. So in 2014, those numbers were 327 and 37, which means that between 2014 and 2015, there was a 27% increase in this. But here's the worst. 2012, 86 overdoses from heroin. 86. 86 in 2012, 2015, 415. And 1 from fentanyl. So I just want to put that out there as some numbers for us to just consider in the top of our head. And I want to sort of start off the panel by asking Sue to tell her story. And before she does that, I just want to say that for what Sue is doing takes a lot of courage. And I'm so grateful that you're here, Sue, to tell Nick's story. And I just talked about it with you for a while in the other room, and I just want to say in advance of you doing this, we're all super proud that you're here tonight to tell his story, and we owe you a round of applause before you begin. Hey, listen, what? Yeah.
So, Nick was my firstborn. He was extremely funny, fun-loving, had this big, contagious smile that just lit up any room he went into. Thank you. And he was very athletic. He either called me or sent me a text every single day to tell me he loved me. He was special. Nick was an extremely talented hockey player. He entered high school coming off the number 6 team in the nation. The number 6 best team in the nation he was on. As a freshman, he was a starting center for the varsity team, which we later found out this is where our nightmare began, in the locker room. His very first game, an upperclassman tossed him a little white pill to help him relax. And I guess Nick must have liked the way it made him feel. Because later he told us that he never skated and played a high school hockey game sober. When all this started, Nick was 14, a 14-year-old boy with his whole life ahead of him. At 19, Nick came to me and told me he needed to go to rehab. I was quickly educated on opiates and the destruction of opiates and addiction. So Nick went off to rehab in Florida. That's a whole nother story. He actually celebrated his 20th birthday down in detox. He was there until June of 2013, so about 8 months. Our intent was he was going to stay there. But Nick had a misdemeanor that he had been fighting. We were flying him home every month to go to court to get postponed. In June, it was no longer postponed, and Nick was now on probation, which meant he couldn't go back to his facility in Florida, probation of a misdemeanor. Had it been a felony, he would have been able to go back and, I believe, have it paid for. Go figure. So here he is, June 2013. He enrolled back at Southern, took a few classes. He got a job, and he got an apartment. A couple months later, I didn't get my phone call or text. That's when I knew something was terribly wrong. I went to his apartment, and that's when I found Nick, and that he had lost his battle with addiction. 11 days before Nick should have turned 21. So I just want to show you, this is your face of addiction. This is our neighbor, our friend, our teammate, our sibling, and our children. Thank you.
Thank you, Sue, so much for sharing that. Commissioner, let me start with you. When you hear stories like that, and you must hear them very often given your job, and you go around the state and do this, what advice do you give to parents who are facing what Sue faced, and parents that may be sitting in this audience who are struggling to get their young people help, or their husband help, or their wife help, or their brother or sister? What does your agency do in the way of trying to provide them answers?
So, a couple things. First, thank you for sharing your story, because I think it's just so, it's so important for us to, often we talk about the numbers and the statistics, and I think when hearing your story and when other people share their story, it makes this, it sort of brings it home. The numbers are one thing, but we are talking about lives. Friends or children or relatives, or and I think probably all of us in the room know somebody or have been impacted by this one way or another. And so when I hear stories like this, I'm for one appreciative, because it makes me realize that information is getting out there. I think we are achieving a level of sort of momentum and awareness raising in the state around just how much of a significant sort of public health crisis this is. And so I appreciate hearing when people share their stories. In terms of some of the things that we're doing, we're also organizing other forums around the state like this, so that people can continue to share their stories, and just the level of awareness building, I think, that happens from being able to share sort of what works or what doesn't work, or what ways where I've heard all kinds of stories around creative ways or challenging ways individuals were able to get their family members into services or not, or some of the barriers to services. And it's helpful for me to hear some of the barriers, because then that gives us a point of potentially intervention. It was one of the reasons why we've compiled this list of different services and assessment centers. At a previous forum, somebody let us know that, it's hard to navigate. It's hard to navigate systems. It's hard to know where to call and where to turn, and And so, we felt it was important then to put together a list of initial assessment centers in all regions of the state where you can get an initial assessment and be linked to services. I think awareness around this is so important and so critical. And many of these centers, I mentioned that we're the safety net provider. Many of these centers will also work with individuals that have private insurance as well. So I did want to put that out there. This is not just a list for individuals that are on Medicaid. It's for individuals who, as well, can be linked if they have private insurance. Can link folks with services there as well. And so those are just a few things. There's a range of other sort of services and supports that we offer. We do quite a bit of training of the police departments around some of the Narcan. That Narcan truly is a life-saving drug. And so the governor over the past years, 2015, 14, 11, and 12, has passed legislation around increasing the availability of Narcan. And so that's one thing that we're encouraging people to do. If there's somebody in your family that is grappling, or we encourage you to get a prescription. Speak to your provider. Many pharmacies are beginning to offer it as well. Have it on hand because there is a window around which you can intervene and save a life. And certainly, call 911. And other individuals on the panel will speak about this as well. Many police departments, first responders have it as well, and that's been part of the legislation. Just one more thing. There is a prescription monitoring program, and that's been, again, part of legislation that the governor passed, where individuals who are prescribed different medications, they have to be entered into, this database. And it really can help with reducing the possibility or likelihood of doctor shopping. So that's one thing. It's a prevention piece. The other piece is, again, turning in medications, any additional medications. And so we continually do advertising around drug take-back days, where drop boxes are, and that sort of thing. So that's a bit.
Thank you, Commissioner. Now, you mentioned the database, and that was actually what I was going to ask Dr. Tobin about. One of the things that was in the law that the Commissioner just referenced that I had the honor of co-sponsoring was that if there was a doctor was going to do more than a 72-hour prescription, they were going to have to go inside that database and check to make sure that that person has not gone to other doctors. But that also brings up an interesting point that I think you and I have spent a lot of time talking about, which is that there's got to be a balance between pain management and what these drugs are actually intended to do and are helping people with in society, and people getting hooked on them. And so, there's one of the bills that I think is being considered in the legislature right now that I hope will come up for a vote is sort of the idea of why 30? Why, when you get your wisdom teeth out, do you get 30 Oxycontin pills when you probably only use 3 or 4 of them? Because then that's the trickling spiral that we see. I'm going to ask the police officers to talk about the box that they have there, but when Sue and I were there, and Betsy was there, and Guilford Day was there last September, we collected 60 pounds of drugs in 2 hours from people. And it was people coming in, and it was like their kids had left the house 10 years ago, and it was their 3 kids, Vicodins from their wisdom teeth, from a sports injury from 15 years ago, that just sit in medicine cabinets. And so, Doctor, can you talk a little bit about finding that balance, which is something you've spent a lot of time thinking and talking about?
Thank you. That's like the best point. These medications, prescription pain medications, have a place in medical care. There are some patients who benefit from them, and I don't think the right answer is just to say they're all evil, because they're not. I think the better answer is to educate prescribers how to use them safely, and patients how to take them safely, and take precautions so that we all keep the community safe. So it turns out that folks who abuse or misuse prescription painkillers, they don't typically get them on the street or from a drug dealer. They get them from family and friends. That's the largest supply. And there is a group that will take them without the family and friends knowing. And the place where they get them is the medicine cabinet. So one very simple and easy thing to do is to get them out of the reach, lock them up, so that your kid in the house or the stranger who's visiting or the babysitter can't get them. You know, they lock them up. And when you don't need them anymore, get rid of them. Absolutely. So, and there are plenty of ways you can do that. These take-back days are fantastic. A lot of pharmacy chains actually have a mechanism by which they can give you an envelope that's secure that you can actually send them in for basically incineration. The FDA says you can flush them down the toilet. The state of Connecticut does not like you to do that. That's actually on the Environmental Protection website, is don't flush them. There's a little controversy there. But an alternative way is you could take them and you could mix them in with some used kitty litter or coffee grounds, something that's going to make it unpalatable so no one else can really take it, and throw it away. That's another way to do it. But having unused supply is a huge part of the problem. So get rid of them if you don't need them. Lock them up if you do need them so that nobody else can get to them. I think another very important part of the balance here is understanding that as doctors, we can't always predict when there's going to be a problem. Everybody's different, and one person can be exposed to these medicines, never have an issue, and somebody else can very quickly go on to develop sort of cravings and addictive behaviors. So since we can't predict confidently for everybody, we have to assume there's some risk for everybody. And so one thing that I try to teach about is prescribe Narcan if you're going to be using opioids regularly. And as a patient, you should ask for it. If your doctor doesn't offer it and you're going to be getting these medications on a regular basis, feel empowered to say, first, hey doc, what's my alternative to using this at all? Like, do I have to take this medicine? Is there an alternative? What's the end point? Like, how do I know that it's working and how do I get off this stuff? This is not like a lifelong commitment to using it in the first place. These discussions are so simple, but they often don't happen. The doctor just writes a script, the person goes, and the next thing you know, there's a refill, and it just sort of spirals on. So this really should be deliberate. It should be deliberate prescribing, and Narcan is life-saving. It comes in different forms. There's a nasal one, which I'm sure is the one that the other panelists will talk about. But there's a newer one, which is like an EpiPen for folks who have life-threatening allergies. It talks to you, it tells you, put it against your leg, hold it here, push a button. So if you're somebody who finds a loved one who needs this medicine and you have no idea what to do, it kind of teaches you what to do in real time. There's lots and lots of options. It's just knowing that it's there. So education is such a big piece of it. And from the doctor end of things, too, one of the things I love about the new legislation is requiring some mandated education for prescribers. But it's probably not enough. There's a whole field of study on how to do this safely. And in an hour or two, I don't know that your doctor is really going to become an expert. So you need to partner with your doctor to be an informed consumer and to help them help you in as safe and effective a way as possible. You mentioned the prescription monitoring program. I'll just very briefly touch on that. I think it's a great tool. And as you heard, when you get from a pharmacy any sort of controlled med, it doesn't even have to be a pain med. It could be for anxiety or for other issues. It's reported to the central database, and then the physician can log in and they can see which provider prescribed it, how many, which pharmacy gave it. I mean, all this information is right here. And pretty soon in Connecticut, that information will become available within a day. So it's really, really helpful. There's this sort of sense of, oh gosh, there's one more thing to do. What I try to tell people is, yeah, this is super important for you to do. It's okay. Take the time through the emergency room, through the clinic, through the doctor's office. Do this safely. And let's make sure that we're not contributing to the problem.
Thank you, Doctor. I want to go to John, who can speak to Narcan now that this panel is flowing very easily, by the way. I didn't intend to go in this order, but they're sort of helping us out with the order here. One of the bills that I've co-sponsored this year that we're actually passing in the Public Health Committee tomorrow is a governor's bill that is going to require that every single town in the state of Connecticut has a first responder that has Narcan. It's going to impact a lot of different communities, but the good news is that Guilford is way ahead of the curve. We've been carrying it for some time now. And I'm just going to ask John to speak a little bit about what Narcan is and if you can explain it to everybody and how it works and how you guys deploy it in certain situations.
Narcan, basically, naloxone, is utilized for anytime type of overdoses, opiate overdoses, that basically what it does is the opioid, once you're overdosed on it, it causes a respiratory depression. Basically slows your breathing down to a point where it may put you into cardiac arrest. So if you're not breathing, basically we utilize this drug which reverses the effects of the opioid and therefore allows you to start breathing again. So with this medication, it's very important that we administer it as soon as possible once we notice that the problem has taken, there's been an opioid overdose. It comes in many different forms. You can utilize it intranasally, which we use out in the field, as well as intravenously. There is, as the doctor mentioned, there is a auto-injector that does actually talk to you to help you self-administer the medication itself. So we see a lot of overdoses out in the field, not only with the young and middle-aged, but the elderly as well. I mean, sometimes you have these patients who are home by themselves, and they'll have the nurse's aide may call out sick one day, and they decide to self-medicate themselves. Well, sometimes they don't take the right prescription, and therefore they overdose on their own. So sometimes we're called in because we have a patient who has an altered mental status. We can't figure out what it is. And the first thing we'll do is we'll administer the Narcan to see if that actually has helped the patient. And that can indicate to us whether or not it was a possible opioid overdose. So not only is it in the young and the middle age, but we also have problems with the elderly. Sometimes they don't take the proper amount. So that's basically what we utilize out in the field. It's been used for many years. Like I said, I've been a medic for 15 years, and we've had it. I've had it ever since I've been a medic. It works. It's amazing how fast it works as well. Saved many lives.
Thank you very much. And now I'll turn to the two officers that are sitting next to both. You both do great work in the community, working with organizations like Guilford Day and young people, trying to educate them on the dangers of this. How do you balance the role of law enforcement and getting people the kind of help that they need? And what are the kind of things that you're doing in the community to make sure that people know that these drugs are really not good for you and should not be tried in any fashion?
Sure, I'll speak first, and I'll let my Officer Anania speak on it also. Our role is a delicate balance when it comes to our involvement between the criminal element and the medical and mental health element of these cases. Of course, there is a criminal element of it that needs to be addressed generally at some point, but it's not our focus. Our focus is life preservation. If somebody needs medical aid, if we respond to an overdose, if we respond to some kind of a drug case, our goal is to get the medics out, to get them addressing the situation as fast as possible, secure the scene, and if there's a criminal element, to handle that as kind of an afterthought. It's a little bit different than other types of crimes that we handle. Our first responders, our patrol officers, our patrol sergeants who are getting there first, they have a lot thrown at them when they enter these scenes, and a lot of sorting out to do to figure out what's going on. But our primary focus is life preservation, just like in any other call. Once a patient is secured, then it's a matter of kind of overseeing the entire scene, looking at the totality of everything and determining if there does need to be some type of criminal investigation. It's not always warranted. There's no straight answer if there's going to be a criminal element or not. There's a lot of factors to go into it. Our focus criminally generally are dealers and not necessarily users. Now that doesn't mean that there aren't criminal charges at times for users, but that's not our focus. Our focus is getting them help. Our goal in getting them help is to get them in touch with the other resources I mentioned earlier, to get them the medical help that they need. We do have an educational portion of what we do. My only detective, who happens to be here in the audience and is extremely involved in a lot of this stuff, runs a lot of community outreach programs. So if you've heard of Coffee with a Cop, if you've been to it, you know how great the program is. If you haven't, I encourage you to attend one. Our talks in the schools, our participation in forums like these, the education role is huge. The more we can educate the families, the more the families can educate their young who may not have the opportunity to sit in front of one of these forums or have the opportunity to speak to somebody at the school or participate in one of these other programs. We're kind of filtering the information through you to hopefully get to them to assist it, before we need to be there in one of the worst case scenarios that unfortunately we do have to make appearances at. So it's not as cut and dry from the police aspect of just getting there and making an arrest. At times, is an arrest the right move? Sometimes a court-mandated therapy or court-mandated probation is going to be the jolt that this person may need to make a decision better than where they've been. Is that always the right answer? No. But it's a reality, and it's something that comes along with the activity. You're never going to get away from it, but it's not as cut and dry as we arrive and somebody gets arrested. It's never that cut and dry. There's a lot more involved in it, and there's a lot more oversight that needs to get through. But our primary focus is taking care of the person, getting them the help they need so that we can, deal with everything after the fact. But the education side of it is important. So again, if you've had an opportunity to attend one of our programs or one of the programs put on by the patrol or the detective units, do so. They're open forums, they're great opportunities to talk. They're much like this, but on a smaller scale, a little more one-on-one attention. It's a great opportunity to ask questions. We have the Citizens Police Academy coming up. If you've heard of this, if you've attended one, you know that another great forum, another great opportunity to get educated on these topics and to ask questions and to have a pretty candid audience and a great variety of instructors to kind of touch on all the stuff that you may not have the opportunity otherwise to hear. Then we have elements like the day organization, which I'm going to turn over the mic and let them speak on that a little more. But that's a few of the different ways we get involved. There are others, but it's a pretty multifaceted response. And again, our goal is to administer as much information as we can and get them, get anybody who needs to be in touch with the right person who may not otherwise know how to do it on their own so they can make the steps they need.
When we go to calls, when we go to overdoses, like he said, we're concerned about the person's life first. That's the main priority when you get there. Say we do find contraband or something, we're going to take that into effect afterwards. We're going to get them medical attention. And if there's stuff that we can't offer them, like services that they're going to need, when they go to the hospital, they also have opportunity there to learn about programs that they may be able to get into. A lot of times courts they just want to make sure that the person's getting help. Obviously, if we pulled the car over and we found contraband like that, it's our job to get it off the street so that it doesn't continue to happen. Like John said, it's a problem with all different ages. We've had people that are in their 60s that we go to an overdose for. So you're not going to say, it's not kids in their 20s all the time, it's all different types of people. And Guilford Day is good because it works mostly with teens, so hopefully they know about the problems, they're being educated as they're younger, so when they grow older, they know, I'm going to have surgery now, I'm going to get these prescriptions. They know how not to abuse them, or they know what can happen if they do end up abusing them.
Thank you. And so now we're going to sort of close out the official panel on a positive note with Dana to talk about the work that she's doing, but I just want to sort of get everybody ready that if you have a question or if there's something you'd like to say, please sort of think of it and get ready to come up to that microphone as soon as Dana's finished. But Dana, many times people tonight have mentioned Guilford Day. Can you just sort of give an overview of what you do in Guilford Day, in addition to what you said earlier, and talk about how people here who have just heard this panel, who are looking to get more involved, can work with you to make sure that we are keeping in the right direction when it comes to prevention?
First of all, I want to reiterate the Narcan training that you did mention earlier. It's on March 2nd, so if you or any loved one, any person you know could use and benefit from that training, we're giving a training on how to identify somebody with an overdose, how to administer Narcan, and you actually do leave with a Narcan kit. So if you want to sign up for that and let anybody know about it, you can sign up at Guilford Youth and Family. It's on March 2nd, it's 6:30 p.m. So I'd encourage you to spread the word about that, please. Guilford Day, so our role really is to bring the community together to create programs and to create awareness and education to help people make positive choices. We focus on prevention. Of course, we do the education piece, which has an element of scare tactic, but really our major focus is on helping kids develop assets, which is why we're called developmental assets for youth. And so we've recognized that when kids have positive peer influence, positive family boundaries, they are valued by their community. These are some of the assets that come into play that help the kids to have high self-esteem, to make positive choices. So the programs we do really focus a lot on those things. What I wanted to do is touch on some of the programs that we are currently planning on. We are planning for our next 5 years. As part of our drug-free community grant, we focus on 3 substances, and we've identified alcohol, marijuana, and opioid as being the 3 substances we're going to focus on. So as we're putting together our education plan, we realize there's definitely a need for education. That education is not only to students and to parents, but also to doctors. What we do want to do is we want to develop a media campaign and also pamphlets or flyers that would be distributed through doctors' offices, through pharmacies, talking about some of the risks of medications, possible addiction, and of course proper ways to dispose of the medicines. We do 2 drug take-back days a year. With that said, I want to accentuate the fact that you can bring back medicine every day of the year. In fact, I encourage you to do so. Our drug take back days are an effort to publicize it. So we do one in the spring, we would do one in the fall, but really it is something that you can do every day. There is a box that's in the police office. They brought back, I believe, 360 some odd pounds last year. Did I have that number right?
Roughly.
Yeah, so it is being utilized. I think we can utilize it more. And the drugs are incinerated, so that's something you definitely want to do, and we'll be further promoting that effort. We also are going to be collaborating, and this is interesting, this is a new effort, we'll be collaborating with realtors and with funeral homes to be educated on the fact that when extra drugs are around, that they need to be disposed of properly. So that's part of our education efforts. We'll be partnering with local pharmacies, providing home lock boxes. So again, the doctor touched on the fact that if you do have medicines and you do need medicines, lock them up appropriately, and then when they're not being used, make sure you dispose of them properly. So really the education is twofold. Let's see here. We will be doing an education piece with doctors and also with dentists, again, on prescribing practices. As you heard, and I've heard many, many stories about people having their wisdom teeth taken out or a knee surgery or something, and they're given 30 OxyContin or 30 Vicodin, and they really only needed 2 to 3 or maybe 5. So that is a big issue, and that's being addressed on a state level, but we will be addressing that also locally as well. As far as getting involved, what we do, again, we are a collaboration, a coalition, and so what we do is we tap into all 12 different sectors of the community, and a big part of that is students, parents, and then of course all the other sectors, whether it be healthcare, law enforcement, et cetera. So what I'd like to ask you to do is, if you're interested in being part of what we're doing, if you'd like to volunteer, if you'd simply like to be informed, I do have a sheet here that's a membership form. I'd love for you to fill that out, and then I can send communications to you, and you can be part of the things that we're doing. And we really could use your help. So
Thank you, Dana. So that concludes our panel. So join me in a round of applause for our panel. Rather than have people come up to the front of the room, I don't want to make people do that if they're not comfortable doing it. So I'm going to ask Megan to sort of walk around with the microphone. If you have a question, just raise your hand. We'll bring it to you and go from there.
Hi, my name is Carrie Federici. I'm a nurse practitioner. I've worked with VA at VA 30 years ago with methadone patients, and now I'm working with teenagers who have addiction problems and other things. And one of the things that I haven't really heard you mention, and education is great. I fully support that, but we need more mental health treatment, because a lot of people that use substances use it because, for instance, they may be depressed or anxious. And I work at a high school, Sean knows, in Brantford. We have a school-based health clinic, and a lot of kids are using drugs because of mental health concerns. Is there an effort to provide more services to people, both young and old, to get mental health treatment so they don't resort to treatment themselves? And also a question for the commissioner. I think that's great that you have that poster, but are any of them geared toward pediatric patients? Because their needs are definitely different than the adult.
So through these assessment centers, many are geared towards adults, but they can link you with other services that would be appropriate for children as well. The DEMA system, we primarily work with adults, and DCF largely works with children. But through these centers, if there's not a site within the particular region, because again, this is broken down by region, that deals with children, then they'll be able to link you with other services that are appropriate for children. The other thing as well, 211 often has can link individuals with services that are appropriate for children as well. So there are arrangements. We're trying to create multiple entryways and possibilities into treatment. And so 211 is an option. Calling any one of these numbers is an option. We also encourage people soon. Actually, we'll be putting out a centralized number, because people are saying, well, this is fine. A listing of different places, but it'd be nice to have a centralized DEMIS number for people to be able to call to be linked up with a range of services in terms of different levels of care. So we'll be rolling that out within the next couple weeks as well. So some of this is available for children, but 211 can help, and then the number that we'll be releasing as well. We'll have options for children as well. And then DCF, the DCF website largely they likely have other resources for children as well, since that's primarily where they focus. And then in terms of your other question, you'd asked also about, I think you're right on in terms of the mental health needs for young people. And we do a training we call Mental Health First Aid. And it's training to help, whether it's teachers, we do this all in schools when we get requests, in communities, wherever we get requests, to help people really recognize some of the signs and symptoms of somebody grappling with mental health issues. Because for some people who are using drugs, we know they may be self-medicating, medicating to help them deal with some of the emotions that may be uncomfortable. So we do mental health first aid training around the state on request, and that's something that we believe is a really valuable resource. I think it's so critical just to be able to recognize when somebody is struggling, and then to be able to intervene as necessary. Thank you for your question.
Also, too, here in Guilford, we are fortunate that we do have counselors in the school, in the high school. One of those counselors is dedicated to substance issues. Also, Guilford Youth and Family Services does provide a lot of counseling, and those services are for both the children and for the adults. Primarily children, but we do see adults as well. Does that answer your question?
Sure. It's just, I think that we need to put more money into that, the front end, the services, so that people don't end up, for 20 years not having treatment.
Yes. Funding is a good thing.
Yes, hi. My name is Charlie Melvin. I'm resident of Guilford, psychiatric nurse practitioner at Community Health Center in Middletown. And 2 boys that are 10, a daughter 5. I think nights like tonight are really what I'm very proud of to be a resident of Guilford. I just want to say that a couple of things, excellent points that have been brought up. I want to say first, Sue, thank you very much for your courage. And I want to say that a couple of days ago, I met a patient who 3 weeks prior, or the previous 3 weeks, had lost 3 of her friends, 2 to overdose, 1 to a suicide. And she herself was using and was distraught and lost. And I share everyone's concern about this growing crisis. I will add that the CTPMP, the kind of prescription monitoring program, is a very valuable tool. It may need some auditing because it's sometimes out of date. It's just a problem. And overall communication between emergency rooms and outpatient services like ourselves. That's a step that I think needs further help. It's important to know if somebody has gone to another doctor, obviously, but the greater context of communication and patient's history, that step is still lacking because our health systems are not shared adequately. So I would make a strong recommendation around that. The other thing I would say is that a great number of the frontline providers for patients with this concern are nurse practitioners. And there are a growing number of nursing programs. There are a growing number of nurse practitioner students who come to the community health center, and they are a growing proportion of our health workforce. It is important that they be empowered to address this with Suboxone, which is not part of the privileges right now. And I speak to a number of patients who are seeking Suboxone treatment, cannot find them because their providers are full. And that is a problem. So nurse practitioners are very concerned about this, as are doctors. So I would encourage further consideration around that. Thank you very much for your thoughts.
I just would add, for educational purposes for people, what Charlie just mentioned was Suboxone. There's two primary ways that people get treated for an addiction like this. One is methadone, which is probably more familiar to you, where you actually have to go to a clinic every day and get the treatment. Suboxone is more of gives you more liberty to get treated sort of in your own way. And you can sort of do it remotely without having to go somewhere. You can do it on your own. As he mentioned correctly, last week on WTNH, there was a very sad story about a couple who literally takes like 15 buses to go from Torrington to Madison to get treatment because that is the doctor that is available to them. And so I think we really, at the legislative level at least, and then people can chime in, we have to do something about that, and we have to make it more available for people because that is recovery is a very frustrating thing. And we need to be putting less roadblocks towards recovery and less things that can frustrate people who are already in a bad situation to walk away from that because we're making it too hard on them to get the help that they need. So I'm committed to that as a legislator, and I don't know if anyone else wants to chime in about their capacity, but it's certainly an important thing we have to address. Other questions?
Hi, my name is Tara. I live in Guilford. I grew up in Madison. I've been here since 1987. My ex-husband grew up in Guilford. He was a police officer in this town. I was a paramedic in this town. We had 2 kids. It was the American dream. Got divorced. Hang on, I'm just really nervous. I'm here to tell about my son. My son was a typical Guilford kid. He played soccer. He played basketball. He did everything. He went to Guilford High School. He was unmotivated, uninspired. A few people tried to help him out, but he was a kid. He refused. When he was 19, one of his friends gave him an oxycodone. He told me that later. He told me that he knew he was addicted at that moment. That's how fast addiction happens. He said all he could think about was doing it again. Within 3 weeks, he was a heroin addict. On his 20th birthday, we were not like you, and I'm sorry for your loss. On his 20th birthday, we were in court, and he got 2 years probation. Wrong place, wrong time. He really didn't do anything wrong, but the probation was great because I said, now I have a babysitter. I have the state of Connecticut that's going to help me. So he goes to his probation once a week, no problems. Well, what we didn't find out until afterwards is you can be on probation and that's fine. They're not going to do a urine test on you. So he was using, going up to the meet his probation officer. Hi, how you doing? Have a nice day. So everything came to a head and we got him into treatment. He went for 21 days because that's what the town insurance would pay for. 21 days, you're on your own. He came home. We went back again, another 21 days. He came home. I'm going to work the program, Mom. I'm going to do it this time. Don't worry about it. He worked the program for a little while. Now we have to go back. Now this is getting ridiculous. I have a kid. I have no money because he's stolen it all. He stole all my jewelry. He stole all of Dave's stuff. On and on and on. He's a good kid. But they manipulate because that's what they do. The drug takes over the person. It's not the person you love. It's a drug addict. While he was in rehab, I called his probation officer. And I said, I have to do something. So she got him in a program. Problem? There were no beds. 4 weeks I had a best friend. He came to work with me. He came to church with me. If I had to go to the bathroom at Walmart, he had to stand outside. I mean, this is what it was. 4 weeks with a 21-year-old man. It was a lot of fun, Dave, wasn't it? So anyway, he went to this 6-month program. He came out, was doing fairly well, and then he relapsed. And he said to me, Mom, I want to go on Suboxone. Okay, what is it? So, okay, that's great, Derek. We're going to call the doctor. We're going to get you on Suboxone. Well, that's a good thought. Because there are only a certain amount of doctors that can give Suboxone. And they can only have a certain number of patients. So, Mrs. Norman, we'll put you on the list. Okay? It was a month later. Another best friend. For a month, I got my son. Here he is. We finally get him in. We got him on Suboxone. I have a good story. My heart breaks for you. I've been to funerals for kids that grew up in this town with my son. My son could not go to the funerals because he knew people would be using it, and he couldn't even be around them. 2 years on Suboxone. He got his crap together. He graduated high school. He's doing very well in college now. But it could happen to anyone. And when I say anyone, I mean anyone. I was a paramedic. My husband was a cop. We were all over guilty, and it happened to us. And reason I'm here, is said, Mr. Scanlon, I believe this Suboxone, you gotta keep working on it because people don't understand how important it is. There were 9 people in front of my son. What happened to those 9? Because I know the last one, she never made it to the appointment. I don't know what happened to her. She just never made it, and my son got in. I just, there's other things I wanted to say that I forgot. Recovery is hard. If you guys know anybody who's using, you tell the people that care about the person. Don't worry about my feelings. If you think my son's using drugs, tell me. Because the statewide narcotics task force followed my son for 3 months. And because they could never get him on a sting, they dropped the case. Did anybody tell me? No. I was oblivious to it till afterwards. So don't think the system's going to work for you. You have to push that system. And I will help anyone. Steve knows me. Anybody who knows me. I'll help anyone. Give me a call. But you have to talk about it. Because people don't talk about it. And it affects everyone.
Thank you for talking about it.
Hi, I'm Bo Hume, and I'm really delighted to follow up on that because the thing that had struck me the most about the discussion tonight is that I know, Commissioner, that inside you are angry, you're ready to tear your hair out because of the lack of resources that are addressing the problems of mental illness and drug addiction. I think it is just pathetic that our society has a problem like this and we do so little to deal with it. It is not, addiction is not something that gets solved with a quick detox and a quick rehab and bang, 2 weeks later you're out the door. It is a long, long, tough haul for people, and many of them don't make it. I've been part of the DAY project for years, and I personally believe that the government isn't going to solve this. Government has to help. They have to do everything they can. But I really believe that society has to solve it. That we have to get involved. We have to teach our kids early. We have to stay on top of our kids as they go through school. I got involved because I had a daughter who became addicted to crack as a sophomore in high school. It happened to her with friends where she was riding horseback. And we were so pleased for her that she had an activity that she was really good at and really enjoying. And as a result, quickly addicted to crack, lost her childhood, we scrambled around with no help that we could find. She ended up in Minnesota being cared for. Subsequently, she had psoriatic arthritis, which is a very painful condition. And the doctor she went to put her on OxyContin. Within about a day and a half, she was addicted to Oxy and went through that whole nightmare. Doctor, I know you too were probably really angry at a lot of your colleagues. Yeah, right. This is a crisis. It's a problem. It's not under control. We're nowhere close to the assets that need to be put into it. And if it happens to your kid, man, kiss goodbye to your peace of mind and a whole lot of money to get through rehab and recovery. But one thing I wanted to mention, really, Commissioner, while that talk is that I believe we need to think about outside-the-box ideas of ways to put more resources into this. Demas will never solve it. I'm part of a group called Lifelinks here in Guilford, where people who are in long-term recovery work to help people who are trying to get into recovery and to find their way clean. And they really, I think the 12-step programs are probably one of the best resources the country has. And this Lifelinks model, I think, is a terrific model. But, you know, it's a few people in Guilford and Madison. It's not going to cure the problem in the state. But that and I see Jane from the Day Youth Group. Last year, the kids came up with the idea of Project Purple, the Chris Heroin thing, and they really drove it. And as a result of the project in the high school, they had a whole bunch of kids wearing purple shirts and purple hair ties and purple wristbands. And the kids could look around and see that the majority were clean, that they weren't the only nerd in school who's, you know, not partying. And I believe that those sorts of ideas, that if the government, instead of being stuck holding the problem and no resources, we're able to think of and find ways that society can do this, that it would be a help. And I would be interested in your thoughts on that.
Yeah, thank you for your comment. I mean, I agree. I think that this is a complex challenge, and complex challenges or problems really require creative, complex, multidimensional solutions or approaches to addressing them. So this is, you know, I often say I see this as an all hands on deck challenge. It's true, government, you know, whether it's state government or federal government alone is not going to get at this. I think it's all of us working together. It's as parents, you know, talking to our family members, talking to our loved ones about, and knowing our loved ones, knowing who they're hanging out with, knowing, you know, so it's difficult conversations, it's difficult legislation, and sort of being steadfast, sort of camping out at the LOB or wherever to sort of get things through. It's all of us working together. It's sort of physicians, you know, there's a number of initiatives in terms of, you know, looking at prescribing practices and patterns. So it really is all of us working together. And I agree. I think that there are, we're out of the box thinking and creative thinking is really going to be critical. One initiative that we have going on that actually was part of 2015 legislation that went through is myself, along with the Commissioner of DCF, Department of Children and Families, we co-chair the Alcohol and Drug Policy Council. And that is a group of community members, of people in recovery, representatives and legislators. It's a really complex, diverse group of folks, and we meet, and it's been reconvened, but we meet, and the goal and the charge from the governor really is, you know, think about best practices, think about community messaging, think about prevention approaches, treatment approaches, and we're working on those multiple levels. An idea I had recently, and I brought this up in my state board meeting, I would love to see us do this as a state. I know we can do this, and I think it would make a difference. You know, there was the AIDS quilt that has been really impactful and powerful in terms of the you know, HIV challenges that as a country we've grappled with. I could see us doing something similar to that in terms of this epidemic. The AIDS quilt is a quilt of individuals who have lost their lives to AIDS, and it includes a picture and sometimes a brief, maybe another square that includes information about the person. And if people are interested in something like that, I think that could raise significant awareness and honor the lives of the individuals that have been lost to this crisis. So in our state board, there are a number of folks. I'm not really a quilter. I did it once, and my square was not really, definitely not usable in the quilt. It was for a baby shower, but I think this is something that could be could really help to raise awareness. And typically, these types of quilts are then they can be sort of displayed at forums, displayed at different community places, and it really does help to raise awareness. And there's something stunning about them too, just to see the lives and the names and people's stories. And it takes courage, I think, actually, for family members to have their loved one to be part of that quilt. But it's, I think, a tremendous way to be able to raise awareness around this challenge.
I want to be respectful of everybody's time, so we're going to try to get a few more in. So if you have one, get them up there. We're going to go to this gentleman right here, and then Megan will head to the other side of the room, and we'll try to just take a few more within the time we have.
So my name is Dr. Mark Bono, and I'm a little nervous as well, but I'm going to say some things, and they may come across as a little controversial, and I think also I'm a little nervous that you're going to think that when I'm saying these things for self-promotion. I'm not. I'm saying these things for you because I have a daughter who had a life-threatening illness, and I had to search for a miracle to save her, and I got my miracle. And every client that walks into my office, because what I do is treat opiate addiction, that's all I do. And I have two practices, one in Madison, which is the one you referred to. And every patient or client, I call them clients, that walks into my office finds their miracle. I've been doing this for 3.5 years. I've been doing addiction treatment for 20 years. I'm an addiction psychologist, which is a rare thing. But I've been doing opiate addiction treatment exclusively for the last 3.5 years. And I haven't lost a client yet. More importantly, my clients, they achieve the kind of results that, I'm sorry, I forgot your name. Carol's, the outcome that you get. I have that. 85% of my clients have that. They come in, they get treated with Suboxone, and they get treated by a therapist who work in the same office, side by side, next to each other as a team. And the mental health component that you brought up, 60 to 70% of my clients have a co-occurring mental health issue. And one of the reasons that opiates are epidemic is that they're incredibly, it's an incredibly diverse type of self-medicating process. So you can use opiates to treat anxiety, general anxiety, social anxiety, depression, unresolved trauma, ADHD. All of those illnesses get short-term benefits from taking opiates. So you do have to have someone who has some expertise in mental illness while you do that. So what I'm trying to say is that in some ways it's not very complicated. We should be using the medication that is the most effective and the safest. And by far, Suboxone is the most effective and safer medication than the other alternative, which is methadone. And as you referred to, the process of getting treated with methadone requires you to go to a facility and stand online with dozens of other addicted individuals who are taking a medication that does not provide an effective relief from abuse, does not provide a blocker for taking more opiates on top of it. And I have been doing this for 3.5 years, and every single one of my clients who've come to me have had a combination of an incredible struggle to find help, and if they've been on methadone, they have been victimized by drug dealers hanging around the methadone clinic in the worst part of the methadone clinics in the worst part of the neighborhoods. They're constantly having drug deals on the lines, constantly having drug deals in the medical cabs, taking them to the methadone clinic. So if this was cancer and we had 2 medications to choose from to treat it, and one was highly effective and less and safer, we would only use that medication. We would discard the other medication. And my practice, my two practices are my offices look more like a living room than they do an office. And there's a reason for that. And if you spoke to any of my clients, they will tell you, Dr. Bono knows me as an individual, knows the issues that are underlying my addiction, and cares about my recovery. And this is my phone that they have, that they can call me 24/7 when the pharmacist doesn't want to fill their prescription and they're in panic, or when they're trying to make a choice about whether to go to a funeral that they know people are going to be using, or one of the millions of things that come up. They know they can reach me. And they get individual therapy weekly, they get medication management weekly, and the results of my practice is unmatched. But that's not because I'm doing something special, because I'm doing it the way it's supposed to be done.
And I want to thank you, Doctor. I want to give the Commissioner a chance to respond to you and get some other questions, but thank you, obviously, for the work you do. And
Yeah, and thank you for your comment. I mean, there's a lot of literature right now that is really research that has been looking at sort of methadone, Suboxone. Really what the research is showing is that what makes a difference is somebody being involved, a person being linked up with some form of medication-assisted treatment and therapy. So that may be that actually, some studies suggest that that's the factor that's making the difference, the fact that it's both medication-assisted treatment and therapy. Studies that look at the effectiveness of methadone and treatment are showing significant efficacy. It's still sort of identified as one of the treatments of choice for heroin and opioid addiction. And certainly what we know is there's no one-size-fits-all approach. Anyway, but both are good. I mean, both are good. It's a matter of sort of what's going to work best for an individual, what's the best fit. People have different preferences. Some people prefer one over the other. And so, what we've tried to do within the DEMAS system of care is really make both available. We have about 25 methadone clinics, and statewide in all regions of the state. We also offer Suboxone, and it varies. Some people, it varies, and the research. People are really beginning to dive deeper into the research in this area. Before I was commissioner, I was actually at SAMHSA, so it was Federal Substance Abuse and Mental Health Services Administration, for about 2 years, and did a literature review on each of these. And right now, methadone is still viewed as one of the treatments of choice, but it's not methadone alone. It's methadone along with counseling, and I think that may actually be the thing that makes a difference. The counseling piece is important. You can't just have the methadone or the Suboxone alone. It has to be, the counseling piece is important because there are, as you mentioned, there are often for many people, there are co-occurring issues or underlying mental health issues that a person is grappling with as well.
Hello, my name's Betsy G. here. My daughter lost her struggle to drug addiction on November 4th, 2013. So she was the one female statistic that we quoted tonight here in Guilford, or Connecticut for that matter. I read all the time about accidental overdose. Isn't all overdoses accidental? Otherwise it would be suicide. Martine's death was anything but. She tried everything to get over addiction. She tried methadone, she tried detox. She went to rehab and sober living. That's not somebody that wants to die. That's someone trying to get better and trying to live. I think we need a lot more options besides methadone and Suboxone. I think cancer has a million different cures. I think we need to work on trying to get more cures, more help, and more funding for our children, for our friends, for our loved ones. I think that this is really killing a lot of our families, and we need to do more, and not just the methadone, and not just the Suboxone, as I said before. But I also think, too, in Connecticut, we don't offer detox off of methadone. When you get down and down and down, and you're on 10 milligrams, 8 milligrams, you can't get off it. I had to send my daughter to Florida to detox off of methadone. And I just don't think that's, if we're going to prescribe it, I think we ought to detox off it also. And the other thing I would like to ask, if you think your adult child is doctor shopping, how do you find out? How do you get them on the list so that doctors can do that for us? How do we get that help? And how do we get a prescription for Narcan? I know other people that have had trouble trying to get that script to have it in their house.
Betsy, I just want to round of applause for telling your story. I'll let Dr. Tobin chime in about the PDMP system, but with regard to the Narcan, right now, all you need to do, the law we passed in 2015 allows you to go into a pharmacy that's participating in this program, and they are required to give you a little bit of training to administer that, because we don't want to give this out without any training. It's a very hard thing to deploy in certain, especially in an emotional situation. So that is available, and actually we're trying to make it more available to people, especially at the nasal level. We really want to try to get the nasal one a little more easier than the EpiPen, as these guys can probably attest to. But I'll turn it over to Dr. Tobin, who can speak to the database.
Yeah, so just to emphasize that point, you don't need a prescription any longer. It's phenomenal. As long as there's a pharmacist who's been trained and certified, you can get it directly without a prescription. So it's a great
So we could just go to CVS here in Guilford and they'll give it to us?
Yeah, so and there's a list that's maintained on, I don't know if it's on your website or one of the Connecticut government websites that says who's trained so far, but the number of pharmacies is expanding dramatically. In terms of how do you tell doctors or report that there's a problem, you know, a lot of people are worried about HIPAA and the privacy laws and being afraid to exchange information. That may prevent me from sharing information with you. It doesn't necessarily prevent you from telling me whatever you'd like. You know, I feel free to call you the doctor. That's really important. And then I'm curious what our law enforcement folks would say, but it's been my experience that sometimes a very concerned parent or loved one, the best way to get them help is to pursue it, you know, if they're not interested and their doctor is not part of the picture, through legal means. You know, if there's a problem, sometimes getting the police involved is the way to go. I don't know, do the officers have anything further to say?
As far as doctor shopping investigations go, they're complicated investigations without a doubt. If the information is brought to us in the sense where you have the theory that someone you know is doctor shopping, especially if it's a loved one or something like that, and we can initiate a criminal investigation. We do have access to the prescription monitoring program that was already spoke of. It's not a perfect system. It's not completely up to date, but it's a lot better than what we had 2 or 3 years ago, and it gets better day by day. We do have the opportunity to log into the system, and we can see in Connecticut what doctors are prescribing to what patients. And if we can see that multiple doctors are prescribing the same medication to the same patient, we can enact a criminal investigation on that and handle it on that side. Is that a cure for that person? No. But we can certainly initiate a criminal investigation, and we do have access to that database, and we can view it and we can see what's going on. Again, it's not a perfect system. It's not 100% up to date. It's good information. It's not perfect, but it's certainly enough to generate a criminal investigation.
Take one more.
Hi, I'm Larry Backus, Guilford resident, and I'm also the founder of citizensempower.org. I have a question. Sean, earlier on, you talked about the dramatic rise in the abuse of opioids over the last 5 years or so. Maybe this question is for Dr. Tobin. From the standpoint of the epidemiology, you know, what happened 5 years ago that would trigger such a dramatic rise over such a short period of time?
So I think this is challenging, this microphone. I think it's actually going back 10 years ago, or maybe even a little longer. You may remember, or maybe not, there was this big push to make pain as the 5th vital sign. And so doctors and hospitals were being evaluated on their, did you assess for pain the same way we're doing for pulse and blood pressure? And with our increased push to doctors to really prioritize this, you know, it led to a lot of additional prescribing of analgesics and opioids. And I think that what you're seeing 5 years later was the kind of result of that. Opioid use and misuse has always been a problem. It probably always will be a problem. But that kind of push really had that unintended consequence. So again, I can't thank you all enough for coming tonight and being a part of this forum and sharing with us. And I'm going to hang around for a little bit. I think some of the panelists will as well if you have other questions. But just let me say thank you to the First Selectman, Joe Mazza.